Hello, everyone. Great to see you, and welcome to the March edition of Johns Hopkins Informatics Grand Rounds. My name is Nick Dobbins. I'm an assistant professor here in biomedical informatics and data science, and I'm very happy to welcome our guest, Dr. Paulius Mui, today. So Paulius is a founder of XPC, which stands for X equals primary care and describes itself as a primary care innovation community, group of misfits in healthcare who like to learn together. And he's also the director of clinical innovation at Next Level Medical. Dr. Mui has degrees in economics from Boston University, as well as an MD from Virginia Commonwealth University School of Medicine. So with that, Paulius, I'll hand it over to you, and everyone, please join me in welcoming Dr. Paulius Mui.
So I'm so excited to talk to you about how I'm thinking about new technologies in the EMR space and simulation space and clinical training space, and nothing to disclose. And the biggest thing I hope that you all take away from this presentation and conversation is just how to look at EMRs differently and how they are really a powerful tool to be used for advancing our training. And curious to hear on your feedback on some of my thoughts in this space. So I think it's always helpful to get to know the person behind ideas. So I'll share a bit of background of what got me here. So it's been over a decade since I got into primary care. When I was working at the Center for Primary Care at Harvard Med School, I got to see a lot of really smart people um, talk past each other often and not have common ground on um, how to solve the most difficult problems in primary care. And that just got me so interested in this space, and I decided to go to medical school at the age of 29 and finished a family medicine training in rural Virginia. And around halfway through residency, I, found it frankly pretty frustrating to be involved in traditional educational institutions because everyone wanted to do good, and there was a lot of emphasis on preventing bad things from happening in healthcare, which is a really important role, I think, to hold the line. But a lot of my enthusiasm and excitement and ideas were really met with a ton of subcommittees and, let's talk about this next year. And around the same time, I came across the health tech world where it was full of optimists and lots of resources. But what was interesting is that individuals building in healthcare often didn't have the right context. And that's where I kind of found my space. And basically, the optimists were a lot more influenceable, and I felt a lot more sense of agency in being in the technology world. And so through that, I basically started interacting with different startups, and that eventually led to my role at Next Level Medical, where I led an innovation team, and we ended up building a lot of technologies in-house that are patient-facing, clinician-facing, admin-facing. And actually, this year, I moved on to take XPC, which has been my side quest for almost 4 years now, as just a place to meet interesting people doing something non-traditional in primary care and healthcare and technology space. And now it's becoming a kind of my main quest, and where we're incubating technologies to advance primary care. And just because I think about primary care all the time, my wife really told me to get a hobby. And so I'm really trying to be good about eating croissants everywhere I go. And so that is a bit about me as a person. This photo has an interesting story because when I was in Boston, I asked a seasoned balloon artist to make me a stethoscope, and that's the first request he's gotten in like 3 decades of making balloons. So that's my small claim to fame. Okay, so to set up the picture here, I think it's really interesting what's happening as a major transition in the primary care workforce. We clearly know that primary care physicians are in demand. different organizations project different level of shortages, but some of the reports that I've put up here, predict as much as 20,000 physicians to be short in the next decade. And there are lots of reasons in the market why this is happening. Obviously, PCPs generally get paid the least, and that has to do with our VU system. We also have this tendency, of the hidden curriculum in lots of institutions of many med students are being told that you're too smart to go into primary care. And so naturally, people tend to not see this as a desirable specialty unless someone is super mission driven. And so if we look at some of the data around how people are entering residencies, more and more spots in primary care specialties, internal medicine, pediatrics, family medicine go unfilled, which is an interesting paradigm, I think, just to observe. At the same time, the market is responding, and a lot more institutions are emerging to allow faster training pathways for non-physicians, so nurse practitioners and physician assistants, to backfill some of these positions in demand. And traditionally, some of these pathways were intended for someone who's been a nurse for a long time, specifically if we're going to highlight the nurse practitioner example, who's been practicing for a while and then decided to kind of up-level themselves. That is the perfect way to support primary care teams and have someone experienced obtain a higher level of training. What actually ends up happening is a lot of individuals see this as a somewhat of a fast track to getting to practice medicine, and often schools have emerged to put people through training largely through online curricula, which is not to the fault of individuals going through the training, but institutions are basically signaling that they'll be ready to face the challenges as clinicians taking care of patients. And that's just a concerning trend for me. And so basically we have a lot of seasoned physicians retiring from the workforce, and we have a lot more of the workforce that just simply has less experience because they're newer graduates and have not been practicing healthcare for a long time. And so this is somewhat of a perfect storm that I think just makes me concerned about the quality of education and training. And I really want to do something about it so that when I interact with healthcare, I don't need to wear a physician hat. I can just be a patient and know that I'm going to be taken good care of. So what's interesting about training in primary care is that we mostly deal with planned care activities such as preventive care and then chronic disease. I think we in residency it's really inpatient heavy across primary care specialties. So we get really comfortable with hospital medicine, acute medicine. We run a bunch of simulation in those places for high acuity rare events like practicing CPR, resuscitations, heart attacks, codes, all of that. But we don't really get I think enough experience and exposure longitudinally around chronic disease. And in a sense, while chronic disease is everywhere, it's almost a rare event to see illness unfold from start to finish. And the reason I'm also highlighting chronic disease is because chronic illness and mental health conditions really make up the majority of the spend in the US healthcare, and people will kind of quote different numbers anywhere from 70% to 90% of the spend. So clearly this is a big economic problem. And the other component related to chronic illness is that the feedback loops are so much longer. So, when we take care of acute conditions in the hospital, we often get to see how symptoms begin, and then there's some sort of exacerbation and then resolution, and that often happens on the order of days to weeks, and we get to see the full course because of how our rotations are structured. But for chronic illness, the decisions that I would make today, we may not know for months or years how whether I did the right thing, how the side effects manifest, how the disease evolves over time. And we really get that feedback when patients come back and, kind of help us close the loop and get those extra data points. And then in today's healthcare climate, we really have patients changing jobs, relocating, insurance gets changed, and the same physicians or clinicians who have been taking care of them are no longer a network. And so that naturally fragments our care experience, and therefore it also fragments our training. And so I think this is a perfect storm for making things more difficult at getting good at chronic disease management. And some of the data on the slide here is that more and more individuals don't just have one illness, and so the complexity just gets that much harder exponentially. And seeing all the different permutations of the types of patients that we get in primary care just simply takes a lot of years of practice. And here's where EMRs come in. I really think that the reason I actually have the FedEx logo here is because I don't know if everyone's familiar with this already, but if you look at the space between the letters E and X, there's a white arrow pointing to the right. And it's not something that's obvious immediately, but once you see it, it's very hard to unsee that arrow. And I feel very similarly about EMRs. Once you see them as a training tool, um, it's really kind of can't stop thinking about it from my perspective because every EMR sandbox that I've interacted with just has often a ton of test patients, ZZ test or 1, 2, 3, something like that. And that's just a way to practice putting in orders so that you know how the mechanics of navigating the EMR work. But it's really such a missed opportunity to actually utilize the entire software as a learning management system. Right now, we kind of use different, web-based portals to categorize learning tools. And I'd like to make a point that EMRs can really serve as that. And in a sense, Stockholm syndrome is when you fall in love with your captor, so to speak. And we have relationships with technology, whether we want it or not, because we spend so much time in it. And so one of the points I'd like to make is basically because we really spend so much time EMRs, and it is far from a perfect place, I think to utilize it as a care delivery tool, but it is something that we might as well try to get really good at if that's where we're spending our time. And so in that sense, the Gutenberg moment is the ability to print new knowledge in in the space that is really not just about being a filing cabinet or QuickBooks to capture accounting and billing. It's so much more than that. And the tailwinds in the market really speak to this notion because there are lots of examples, different companies already utilizing EMRs for training. And so, for example, EHR Go is a purely teaching dedicated EMR. SimCare AI is a Y Combinator venture-backed startup focusing on simulating tools, not purely an EMR experience, but it is kind of one of the latest venture-backed startups in the simulation space. Scope is another EMR that is dedicated to teaching. And then ChartFlow similarly. And ClinicMind is an interesting platform that is an AI-based simulation for patient scenarios and learning out of Stanford. And these are just a few examples that are beginning to emerge in this space related to simulation and education. Their entire conference is out there focused just around simulation tools. Um, even Epic, which really dominates the EMR world nationally, has a program called Lyceum, which was introduced a couple years ago to get medical students more familiar with EMR tools. And I practiced some simulations, but from having talked to different deans who evaluated the software, it tends to be a lot more about learning Epic than truly focusing on the didactic element of learning medicine. But I hope that continues to evolve and change as the capabilities and the technologies evolve. And so here is it. It's really fascinating to think about how. So if we buy the premise of EMRs can be used for education, how does this apply to the modern methods of learning, and how can we empower generalists? And if I'm talking about primary care here, where we can have the most impact in chronic disease learning, the way I'd like to think about it is almost like what happened in the developing countries, where some of them went from no phones to cell phones and just skipped the landline infrastructure because the technology was ready. And I think similarly here, we have the opportunity to have really precision training I think, activities and curricula for students to, whether students or actually people practicing in the field, to become hyper specialists and in in addition to being generalists. And so they kind of get to almost leapfrog the organ-based traditional training. And so I think a good way to think about it is that you can look at a community where someone wants to work or where someone trains, and look at where the demand is from the disease burden. And so if there are certain types of individuals, let's say, in Western Massachusetts, you might have a community of Portuguese-speaking women that struggle with gestational diabetes. You can actually create representations of those patients inside of EMRs, and you can let people practice taking care of them and find ways to mimic years of disease progression and exacerbation in weeks to months, so to speak. And I think this is where there's that really cool fusion of precision medicine and advancing health equity and focusing on populations that maybe don't, that are not as frequently represented in training, or just sheer luck of who you're going to run into. Um, for example, when I finished rural family medicine residency, um, because we did not have a lot of specialists around, we tended to take care of really sick individuals with mental health illnesses, schizophrenia, and bipolar. And we often prescribed medications that uh, only psychiatrists would prescribe, but we just had to learn a ton on the job. But even then, I came out of training having gaps in certain patient populations and disease states. And there's not a good way to gain those skills other than on the job, and actually learn through patients that you get to see earlier in your career. And a lot of that has to do with luck and who you run into and so on. And I think kind of related to that, patients don't really know that the clinician taking care of them, how many of the patients they've seen who are like them. So that can also, I think, change not only how we obtain skills towards being a lot more targeted and getting reps in certain diseases that our communities tend to have. I think patients might begin to get insight into the clinicians that actually have the skills to treat the conditions that they have. What I'm describing is really not a completely new phenomena. I think this has been this topic has been written about for quite some time now, and want to shout out Dr. Vishnu Mohan, who's had multiple conversations with, and he's a co-author on these papers highlighted here, where this has been thought about before to a great extent, and different studies have been run, and a lot of the research that has come out really shows positive experiences and outcomes and being able to simulate things that are important for education. Like even, for example, looking at some of the ACGME requirements for residencies, there are mandates to be able to simulate near misses in clinical practice, and for trainees to be able to reflect on those experiences. And what often ends up happening is that these teaching moments basically often happen in the hospital. And so I think utilizing EMRs and setting that up where we can actually simulate some of the near misses and other teaching points for chronic conditions is a really interesting opportunity. And I've not quite seen that anywhere. To be able to do simulations at scale, data that includes patient information is needed. And so because working with PHI and real patient data is obviously sensitive and has different implications, either de-identified data sets or synthetic data is the two different approaches for this. So there are data sets like Mimic, which are de-identified and represent real patients out there. And then we have some of the resources like Cynthia that have synthetically generated patients to utilize in the simulations. My observation with some of this is that whenever we use de-identified data, it's based on real world data, but it's some of the shortcomings are around also representing of things that happen in the EMRs and in care delivery, but don't actually, maybe it's sometimes not all the times the right thing to do. Like people have different practice patterns that reflect real world needs, but maybe stray away from guidelines because some of the context is not always captured in EMRs. And that's just not a high fidelity representation of maybe how we should teach more of the perfect way to capture HPI or follow protocols that we strive to adhere to. And so I think that is one shortcoming of the de-identified data, that sometimes it isn't high enough quality. And then on the synthetic data side is that it is similarly doesn't always represent the context that needs to be taught. And so as I went out to see if I can obtain and actually utilize some of these data sets in training, found it to be pretty difficult to at least meet the standard that I was looking for. And so some of I guess one approach that ended up being happening is the need to curate my own data set. And so, for example, I got an EMR and just this exploration of education and training. And in that EMR, I'm putting in synthetic data that really represents the clinical patterns that I've observed in practice. And kind of thinking about it as more of like a highly curated, Michelin star chef approach where you like every word in the EMR matters because if we're writing the textbook in this way through the simulated patients, we really want to showcase like what is the ideal way to write an HPI and what do we want to try to capture on a physical exam so that it is the exemplary method to strive for. And so some of the work and explorations that I've been doing here is basically creating charts that are half finished and then handing them off to the trainees and then letting them, so to speak, land the plane and take over for the medical decision making part. And this is where things get super interesting because this type of learning is different from multiple choice, where you're just kind of forced into picking the medication name or, the disease diagnosis. Here, you actually, you can observe trainees go in every possible direction. Some order more tests, others prescribe immediately, but not with the dosage that they needed to, or they tend to just do things very differently in one region. So, like, I've been working with med students and residents, and some people on the West Coast tend to have certain prescribing patterns versus individuals on the East Coast. And I think it's just a really interesting way to get insight into how learning happens. And when you kind of have this free form expression of that is representative of the real world, where patients don't come in with multiple choice answers, you kind of get to observe how people struggle with uncertainty and the many directions that they go in. And then that is such rich substrate for that data can be utilized to actually tailor educational interventions in a very precise way for individual learners. And I certainly hope that more high fidelity data sets emerge to facilitate this because right now this is a really labor intensive process. Okay, so this is also quite fascinating because one, synthetic data is not real, so we can actually not have to worry about PHI, and that allows us to put it into different LLMs to actually see performance. And so this is an example of the previous slide that had the patient with UTI symptoms, but no plan documented, to just screenshot that as a prompt itself into all the different LLMs, just asking, what's the next best action. It's really cool to study and see how different LLMs, what responses they produce. What's been, I've been trying to observe different patterns, and it's kind of interesting actually finding that, like, I think ChatGPT is generally the best model so far to my liking as an all-purpose model, but it tends to do like quite well on like upper respiratory and cardiovascular issues. But Claude, for example, like is really good at MSK stuff, and which is, you wouldn't. I'm kind of curious. I don't really know why these different patterns emerge. This is just more anecdotal observations, not necessarily, hard science, but there's certainly an opportunity to put data around this type of experience. And then, this is a newer model of Gemini, but Gemini, in my testing with the UTI patients, for the longest time, just always needed to order an urine culture before suggesting a recommended treatment, which clinically is not indicated in the case that I was creating. So that's just a really, really interesting observation. And so in the same way, the analogy here is that we're basically, when we train medical students, residents, nurse practitioner students, whoever really, we create, um, we pre-label the data with inputs and then we have them react with an output. And so, I mean, in a sense, we're almost like benchmarking humans too. And this process can be very much applied to benchmarking technology. And so I think there's just lots of white space to advance like our understanding of learning and different targeted interventions following this approach. I also think that what there are websites and tools that are emerging. This was a couple of weeks ago, Med Arena out of Stanford, um, that basically kind of lets you compare the different models. You can put in your prompt, and then it'll show an output A and output B, and then you kind of get to vote which one you prefer more, or is it a tie or neither? And then you can see the results are revealed, which model was actually which response. And I think that I've not seen anyone integrate this type of approach into LLMs inside of EMRs. But I think we probably will get to that point at some point. And this is borrowing more from how some of the coding tools like Cursor has the ability to just switch which models you want to run on the code that you're writing and evaluating. I mean, to me, that's pretty analogous to what might be happening with EMRs in not too distant future. So some of the questions that really, it's one question at this point about um, building a flight simulator for primary care. How would people in the audience approach this? I would love to have a conversation or discussion from the crowd. And how can you challenge me to think about the limitations, the difficulties entering this space, and any other ideas that someone might have, um, from I think from all domains, whether it's the just the technical challenge, the operational, the business, all of the things. And so I'd love to crowdsource the group on this topic. And this brings me to the end of the presentation. This is how you can get in touch with me. And Nick, I know you might, if you've gotten any questions in the Q&A, love to take them or chat about anything else.
I see we've got a couple items, and I think Dr. Harold Lehman maybe has a question as well. Harold, would you like to go first?
In the week before grand rounds, we have the students kind of preview what the grand rounds might be, and kind of you just talked about crowdsourcing. We kind of workshop some ideas, and one of the ideas we were talking about was, are using the EHR, the current EHR, or are we thinking about what the EHR should be? So you said a lot. There's a lot that's really interesting, but I wonder if you could kind of resonate back and forth by thinking about how an EHR should help in teaching on the job. What should the EHR be in order to do that, which is different from the way the EHR is today?
Yeah.
You follow what I'm saying?
Yeah, I agree. And I think my thoughts around, I think it's kind of that concept that every EMR, and I know I say EMRs just because it's easy, it rolls off the tongue easier, kind of like EKGs instead of ECGs, but there's so many, I think EHRs technically is a more encompassing term. So I'll just stick with EMRs for consistency's sake. But
We'll have the language police come after you later.
yes, yeah, I know. I'm probably breaking all sorts of rules. Um, I think that the fact that every EMR has a sandbox environment and also the workflows are so different in every piece of software, the goal would be to use native environments where people work as the place to practice. So kind of, you practice where you play, so to speak, and have that home court advantage. So I think that would be just comment on I don't think everyone needs to go to external resources to like utilize a
No, no,
specific.
no. I'm push. I want to. I'm pushing you. I agree with you that they should be practicing the environment they used to. I'm arguing that the environment they used to is. I was going to use a bad word, but is not designed optimally for the type of education you want to do.
Agreed.
So,
Agreed.
right. So a big thing that came up was that EHRs are not designed to support cognitive processes. The
Mm,
information is all over the place. It's not
mhm.
problem specific. It's not patient specific. It's not disease specific. So I'm, I'm encouraging you to be thinking forward to thinking what does an what should an EHR be to support the type of education simulation and the teaching, the cognitive teaching, or maybe a non-cognitive teaching that they should be getting out of the EHR. It's kind of the next.
Yeah, I agree.
So
It's definitely a higher level of thinking, a philosophical approach to how can an EHR be
well,
utilized.
that's my job, but okay. But anyway, I just wanted to encourage you to do that and think about it.
I love that. Yeah, I really appreciate it. And I do think that, I don't know how many years from now, but we probably, as technologies become a lot more AI first and voice first, we may not even utilize it and look at a screen at all. But
Mm.
I think that you also have to, build for like the present, so to speak. And so there has to be some in between state, but you're completely right. And, like speaking to reimagining how unstructured and structured data lives in the visual interface. Like a colleague of mine is building river records, which is a kind of a different take on an EMR experience where everything is problem based and it's actually around problem cards. And whether that's the right approach or not, people are experimenting and there's a lot of uptake. And um,
uh, Larry Weed had knowledge couplers back in the 70s with
mhm.
the same theme, and David Bergman back in the 80s and 90s tried to get AAP to do that. Had a startup for that, so it's in good company.
Yeah, okay, great. Yep. And sometimes the ideas are really not that new, but the conditions for the ideas to thrive like are just there, right? And just um
Well,
so so
okay, let me pass on to other questions. Thank you very much.
yeah, thank you.
Great. Well, we have a few coming in the Q&A and one in the chat. I think I'll take the liberty of asking one quick one if I could, Paulius, if that's all right. And this may be, just I have a natural language processing background. I just have this drive to just measure things, and maybe I should
Mhm.
stop trying to do that. But one thought that occurred to me, how would we, is there a way that you can think of, just kind of thinking out loud about how do we actually measure at a given institution, at a given clinic, wherever, that an EMR is underlearned or underutilized or something like that? Are there ways that we could actually say, that one institution has more of the EHR's LMS approach than another, or is
Mhm.
that just hard to do? And then kind of a follow-up question, how would we actually give that feedback to individuals? How would we let people know, hey, there's ways we could, leverage the EHR or EMR, now I'm doing it, to help provide that.
Yes. So, couple thoughts around that. The way I compartmentalize training is I think about clinical excellence and operational excellence. I mean, obviously there can be other dimensions to it, but we mostly talked about clinical excellence. It's like knowing what to do. You have this condition, this diagnosis, you do this treatment. And now clinical decision support tools really like take that, make that process easier. And obviously I didn't even talk about de-skilling and all the other automation biases that happen because of that. But then we also have this element of operational excellence, which is not a thought at all in training, at least. I mean, I finished residency 2 years ago, so it not been in my purview or my educational exposure. But, you know, healthcare is a business, unfortunately, especially in the US. And so like operational efficiency drives so much of everything that we hear in the news that, leads to the pajama time, the burnout, right? And what I mean about specifically about operational excellence is actually learning things that are not tested for the boards. Like how do you navigate an inbox efficiently? You get a message of can you help me order diapers? I mean, is that a physician's job? I mean, whose job is it, right? But like this is what patients need. And how do you escalate this? Do you get the patient to come back? Do you deal with it by sending it to the MA if you have one that you're working with, right? Like these are the types of problems that I think can very much be simulated, and people get to learn how to respond to the real world challenges that we just, I think, like brute force have to deal with because there's no other alternative. And on the operational and measure question around measuring is um, I've been experimenting with basically utilizing tools for engineers when they're building software. There are all these tools to monitor bug reports and errors that happen as software gets built. But the same technology, especially when you're dealing with non-PHI data, can be utilized to get pixel level details on how individuals move in the EMR. And you can actually see, like, do they toggle up between different tabs all the time and how they do the chart biopsies. Everyone has a different approach. And and I mean, the way practices measure this in the real world is they look at, either billing patterns or how long it takes for people to close their notes, because some people obviously fall somewhere on the bell curve, right? Some people are really efficient in what they do and others aren't. And using tools like that, basically like replays of the pixels that how people navigate, that could be an interesting way to measure whether someone is being and I guess optimizing for operationally. Whether, I mean, the other debate is, should this even be part of training? Is this more of the postgraduate type of higher level thing? Because we only have so much time in our medical schools and residencies. So that's one thought about training and measuring. I think when I used Epic, I mean, there are all these tools like Slicer, Dicer that you can kind of monitor disease states and like population level data. I think if we had you know, the same tools really can just be applied to synthetic patient panels. And I think you made a comment about the LMS. I mean, I don't think there's a reason why students couldn't have a synthetic patient panel to follow throughout their training. And instead of just going to different PowerPoints and different lectures and trying to do a lot of like pretending that this is the case that you're examining, like you could actually feed that data and result orders throughout one's training career and actually kind of progress over time. I don't know if that's going to happen, but maybe. I think it's very hard to have institutions take that up because it challenges so much of what already exists, which does work, right? Like our systems are really good to produce capable people. Uh, but maybe it's going to be one of those product-led growth approaches that takes hold in the market where students band together and they want to have their own EMR where they get to learn and do stuff because the institutions are just not evolving fast enough to catch up with technology. And I think this is even more relevant for things that have a big gap between what we're taught and what the market wants. Like there's a bunch of issues with direct-to-consumer medicine where people just want to get the testosterone or the Viagra refill without actually like understanding why some of the underlying issues exist. And we don't quite get taught how to interface with that. And I think with simulated patients, you can actually fill those deficiencies. If people are interested in learning how to prescribe testosterone, they get to, I think, do that through the simulations. So anyway, those are my thoughts. I don't know if that exactly answered what you were getting at, but
No, that was great. I appreciate it.
Yes.
And I want to be mindful of time too. We've got an ever-growing list of questions from the audience, very very
Okay.
curious. So we'll try to get through those. So the first, I'll just kind of go in order. The first asks, and it was anonymous, it looks like, but it says there was or is an MBE, I'm sorry, MBME or a US MLE uh,
Uh-huh.
effort to create virtual patients for learning and testing. And a trap was that students or trainees uh, or gaming virtual encounters for points. And I apologize if I'm reading this incorrectly, whoever put this in. Are there tools for scripting case presentations like the old NEJM case conferences?
So I would say, AI is actually fairly good at creating synthetic data, but so you can just ChatGPT, Claude, whatever tools are out there are good enough if to accelerate the manual process. So if someone doesn't know what they're creating, it definitely falls short. So you kind of have to, I think, have to have some domain expertise to leverage them in the right way. I think the Clinic Mind out of Stanford is, and right now they're in beta, so it's not open to everybody, but they have an ability to create very specific patients using AI, and then you kind of get to interact with them in a more sophisticated way. Um, so I don't know if the question was around how do you basically create those patients faster, better using technology, but
That was kind of my interpretation. Yeah, yeah. So
yeah.
that makes sense. Great, thank you. Next up, Lydia asks or kind of points out, in Canada, the real time for a walking clinic visit when I was working there at the time, this is in November 2019, looks like, was just 3 or 4 minutes. Um, do models exercise this kind of real life extreme scenario, or hopefully I'm kind of reading and getting the nuance right there, Lydia.
So basically, if the real world experience of taking care of patients is, has really significant time constraints, how does that get represented in the training environment?
That's my interpretation.
Yeah,
Yeah.
and so I mean, the cool part is that like this is like software is magic. You can create whatever you want, and so like it's almost like when I talk to people who are in this space, it's like you're like you're building the matrix. Like you can create and dilate and contract time in any way that you want. And I think this is I don't know if it's a non-answer, but you can do anything. And I think that if I think there are some questions in the chat about like what are you actually testing for? Like what is the point of this? And the point is actually to have the flexibility to test for anything. And it's just depending on whether you focus around patient needs, where these are the conditions in the zip code where we have for training around. Therefore, we, derive those, or in the example around time constraints, if this is the bottleneck and these are pain points and there's no good way to get at it, then we create simulations that make people, become more efficient with the times that they have. I mean, this doesn't, some of this is like putting band-aids on the bigger issues, like why are visits only a few minutes long? And actually, was it last week or this week? I came across a paper that showed average visit times in primary care across the world, and like 50, I think in countries that cover more than 50% of the population, it was less than 5 minutes. And like Bangladesh, it was
Oh,
48
right.
seconds. I mean, whether some of those studies had data issues or whatnot, but yeah, I mean I think that's a different topic about why are things this way.
Right. But I mean, also, if that's the reality, perhaps we should kind of rethink, um, and kind of retool a little bit so that providers can prepare for that. Or maybe that's already done better elsewhere. I don't know. I'm just kind of thinking out loud. Great. Well, let's see. So next up we had, so Zahid asks, is the core learning around optimizing documentation, or is it to improve practice?
I mean, definitely improve practice. However, that's my like what I where I think the most educational ROI is. However, if you think about the audiences of an EMR, you have one yourself because you're leaving yourself a note for when if the patient returns, you give yourself a hint what to do. The other audience is your colleagues. If they see the patient in a different context in ER, they want to know what happened in an outpatient clinic. Um, there's a legal audience, which, if things don't go as planned, how do you show that you've done the standard of care? Um, and then there's a billing audience, which is like, have you included enough information for the prior auth to not get kicked back if you're prescribing an expensive medication? Um, there are a couple other audiences. When I think about it, there's like six audiences. I feel like I'm missing one, but it really depends on who you're optimizing for. And that's almost like it's like, that's why some of these notes get so bloated is because we're trying to address all the different audiences in like one document. And um, yeah, so I think it depends. I feel like I'm not trying to avoid the question, but it really depends who you're optimizing for. I would love to optimize for people being smarter, more capable, both from the clinical excellence perspective, but also from operational excellence.
Right. And that's actually a good follow-up. I mean, Dr. George Kim right after asks, what's the goal? What's being taught or tested? Is
Yeah,
it diagnosis? Is it patient engagement or EHR navigation? I think you kind of spoke to that a little bit. I mean, I think that's a decision that needs to be made, when designing the training for EMRs and so on. I mean, what's your take on that?
yeah. So actually, Ada mentioned patient is the audience too.
Mhm.
I mean, right? Because like, with open notes movements and actually, so many people are involved in that these days, which is really cool, right? I mean, ultimately, everything we do is about patients and empowering them with knowledge and tools and resources. And yes. So, can you add a bit more context for the last question? I think we can go in a couple directions there.
Sure. Let's see. Well, and I do want to point out too, it looks like there's a number of folks kind of agreeing with that last comment about the patient kind of being the audience and the goal for the EHR. I don't know. I think we covered most of this. I mean, I think Dr. Kim just asked, is it diagnosis, is it patient engagement, or EHR navigation? Was that the last item that you recalled, or
Yeah, I almost think um I mean a good way would be to just see what the variation is between different settings. And so I think like if we look at why are people delivering care frustrated with the way that we have things in the system, it's because they often have to take work home, especially in primary care. And so if we're solving that problem, then I mean, some of it is around navigating in the EMR and how can we, whether it's interoperability issues or within EMR interoperability. I don't, I think this is a broad question, so I don't know if they can maybe ask a follow-up related to it, but it honestly comes back to what problems we're solving with this tool. Um, and the interesting part is that we could technically, prioritize what's most important and then go down the list and tackle all of them.
so next up, and I see someone else thinks this is a good question too, hopefully. So Sneha asks, how much can the CDS or the clinical decision support features be utilized for active learning beyond alerts in quotes?
Yeah. Okay. Really cool topic. I don't think I have the answer, but so Nicholas Carr has written The Glass Cage. It's a book about automation. I believe that's the title. So a lot of what I share, it's a mishmash of other people's ideas, so not my original content, but um, just the observation, which is kind of like a bit, disheartening, is that the people that are building tools or people that are funding people who are building tools in this space often see humans as the weakest link in healthcare. and like that, that's really not the case, right? Like what I'm trying to do is I really want to index on humanity and index on making people more capable, and actually like that's what matters, because we end up having technologies do things that that technology simply can do, and then humans pick up the rest, as opposed to really being thoughtful and taking the human first approach and okay, what actually needs to happen? Therefore, we build for it, and then technology picks up the rest. And so, if we look at literature and from the airline industries, like automation there was really sophisticated a decade ago. I mean, a couple decades ago, really, uh, where looking for patterns and deviations from the status quo is humans are super bad at that. When something doesn't goes off course, because let's say we go on autopilot and we need to pick up subtleties that I think result in adverse events. And this is from studying plane crashes and all of that. And this is just not something that humans are good at, but technology is. But that's what ends up happening. And therefore, some of these autopilot systems are getting redesigned. And I think people who are thinking deeply about clinical decision support and like alert fatigue and all of that, this is this really, I think, automation and the potential for de-skilling, where people just really, become um, like pushers of buttons, so to speak, without putting much thought in it, is what unfortunately might end up happening if um, I think if we don't invest in people learning how to utilize technologies that will support who they want to be, like as their role in healthcare. Because if we, so I think that's just something important to guard against and have an opinion about. Because if we don't actively advocate for how technology should evolve, then like we're just going to be takers of that someone often outside of healthcare builds for us. And I think that's where the tide is shifting is, my path is not unique. A lot more of my colleagues are getting frustrated, and they're trying to find a voice in the startup community in the healthcare space to advocate for things to be built with clinicians in the loop, not as an afterthought. Um, so I don't know if I'm just kind of biased because these are the individuals I'm surrounded with. Um, but I certainly think that there needs to be a stronger collaboration between the two. Like earlier at the beginning of the presentation, I was sharing like how frustrated I was in some of these institutions that move at this snail's pace. But like you cannot work without them or outside of them. And I really think it's about building bridges. And I mean, honestly, like this interaction is an example of that, where we get to bring the different domains together and try to have discourse around it. I think the hard part is making it actionable and finding the people who really are obsessed with getting stuff done. Um,
Right. Great. Well, I see we're getting close to the top of the hour. I don't think, I'm sorry, everybody, I don't think we'll be able to get to every question. There's one quick clarifying question Jeff asked that we'll address, and then I think Jorge will have the last question here. So real quick, Paulius, Jeff asks, what was the name of that book again? And I think you mentioned a book at some point.
I think it's called The Glass Cage by Nicholas Carr, Carr. The Glass. And definitely send me an email. Yes, The
Right.
Glass Cage.
Right. And
I got it.
everyone should, like a little bit a ways up the chat, I did put Paulius's email in there too, so feel free to reach out.
Yeah,
And
so
then
I wrote the book, give the Amazon link, and here's my email again.
perfect. Okay.
Definitely reach out. I mean, I'm kind of making my main quest is exploring the space and seeing what can come of this. Nothing has completely like crystallized or materialized, but this is what I'm exploring and curious to meet other people on the same path. And
Excellent. All right. Well, I know some folks have to drop off. Last question. This is from Jorge. And Jorge asks, why do you think so much effort today is spent in reconciling, annotating, and navigation efforts for clinical contextual relevancy, if in fact the EHR is supposed to represent the patient story in a moment in time?
Yeah, I honestly think that's a hard question. A really good question. Um, well, one is we only selectively put in like we filter what goes into the EMR, um, and I think this is a discussion. Also, maybe we can continue it after this, where scribes now are being utilized everywhere, and they supposedly capture things verbatim, right, and summarize. But like one example is that because some patients might say, I have chest pain, but knowing their context and actually like either from prior visits or just by looking at them and seeing like it actually is you should not necessarily all the time go down the cardiac etiology pathway. And so I think it's often about having follow-ups and teasing out what the patient truly means. And and someone referring to chest pain might actually mean a tickle in their throat, and they just like don't have the same language to express it the way physicians do. And so therefore what we put in the EMR tends to be based on a lot of follow-up questions and prodding and understanding the history so that we document what we think is happening. And I think if we put like everything that is being said, this is where it could create a lot of confusion and then get into doing things just to CYA for medical legal reasons as opposed to actually trying to solve the the patient's problem, whatever that may be. So I don't know if that adds clarity to it, but it's a really fascinating topic. Yeah. Thank you for the questions. I really enjoyed this.
Yeah. Yeah, thank you. Yeah, and that's a great note to end on. Thank you very much, Paulius,
Yeah.
and everyone hopefully has your email now. So if you're okay with it, we'll hopefully get some follow-ups there. And thanks very much, everyone, for joining us for Johns Hopkins Biomedical Informatics Grand Rounds. And we'll see you again next month.